Good morning, everybody. It's morning. I usually record at night. Welcome to the BariAftercare podcast. And today we have some really impressive speakers. I have only just found these women. And when I did, I was like, where have I been? I cannot wait to find out more about what these ladies do and how they can help everybody in the bariatric community. And I think they go a little beyond just bariatrics, which, of course, to my heart is just joyful because I like to look beyond bariatrics and look at your whole life. We are whole, complete people with whole, complete lives. And so I think it's important for us to sometimes direct the information on the podcast directly to bariatrics, but I want to go a little bit beyond bariatrics. So today I want to introduce you to the women behind BariEDucated. And I am just anxious to find out where they got started, how they collaborated in this really brilliant collaboration. You'll understand when you find out their backgrounds. It's Chandra Evans and Kelly Broadwater. Welcome, ladies, to the BariAftercare podcast.
Thank you so much for having us.
Oh my gosh. So I don't know how in the world it took me forever to even find you. I want to hear all about each of you, how you started, what your backgrounds were, and how you decided to put this brilliant combination of registered dietitian and licensed professional counselor together, which I got to hand it to you, is brilliant in this community.
Thank you. Yeah, we've been hiding out in Wilmington, North Carolina, Connie, but I'm
Oh,
originally from the Atlanta area. So,
really? How
yeah,
long have you been in North Carolina?
over 20 years now. Yeah.
Okay.
Can't
Yeah.
leave the beach.
No, I
Um,
can't imagine you could.
but yeah, we got started in the bariatric space 20 years ago, a long time ago when it was kind of
Yeah.
first emerging.
Yeah.
And there were two surgeons in town, and someone found out that we were eating disorder specialists and said, hey, it would make sense that they're the ones doing pre-op stuff for you because they've got that background. And
Right.
so we did a kind of a crash course on bariatrics because back then it wasn't, as
Right.
big of a thing. And then it just kind of turned into our life's work, and we've collaborated ever
That's
since.
so amazing. So you both started at the same time
Mhm.
ish. All right. What were you doing? You were working in an eating disorders. Were you working in a treatment center? Were you working in outpatient? What were you doing at that time?
Outpatient,
Okay.
doing outpatient, I was doing therapy and she was doing nutritional counseling. And
Cool. Were
um,
you working together at that time?
yeah,
Oh
yeah,
my
we've
God.
always worked together.
Okay. How do you guys know each other? Going way back.
Yeah, just from work, just from being at the Chrysalis Center together. We've literally worked side by side. Our offices were next door for 20 years together. So
That is wild.
Yeah,
Okay.
this was like back in the day. Chandra faxed in her resume after seeing my business card somewhere and said
Seriously?
she had just moved to the area and said, I don't know if you're looking
Oh,
for a dietitian at your practice. And
that
yeah,
is great. So, Chandra, had you specialized in eating disorders?
not until I started working at Chrysalis now.
Okay. All right. Yeah. Okay. So, yeah, my original work when I was in my master's program was in eating disorders at a college counseling center.
mm-hmm.
And I had a raging eating disorder of my own when I was in college. So I am no stranger to either the eating disorder field or the bariatric field. So I started back when you guys did. And when I started, again, there wasn't bariatric centers, 5 in a city. And when I started, there was this guy in South Carolina, and he was a psychologist, and he had come from the alcohol and drug recovery
Mm-hmm.
field. And he was working with a surgeon who would not do surgery on patients if they didn't go through this guy's, I think it was like an 8 or 10 week program before they had surgery,
Oh,
which I thought
wow.
was brilliant.
Yeah, it's pretty revolutionary, even especially back then.
I know. And I wish that insurance companies would have adopted that because
Mm-hmm.
as soon as there became so many programs available, people didn't go there because there was a program fee, which paid for his pre-surgical education piece. And it was really sad to me when that went away because patients were given so much information that would have helped them long term after the journey.
Yeah.
So, because we were all, original in the field pretty much, where did you get your information about bariatrics? How did you educate yourself about that?
I mean, mainly ASMBS.
Hmm.
We're both integrated health members and have been for a long time. I remember reading like weight loss surgery for dummies back in the day because
Right?
there weren't a lot of books and there weren't, the internet wasn't and social media weren't what they
I
are
know.
now.
I know. So, when did your book come out? Tell us, let's start with that and then we'll kind of backpedal a little bit. But you guys have a great book, and this podcast is geared more toward patients, but
Mhm.
they all work with professionals. So if the professionals with whom they work aren't familiar with your book, they could perhaps drop a little seed for them. So tell us about your book and how that came about.
You wanted to?
Yeah, so we wrote for about 3 years together in our free time, and it was just published in May of 2023. So it's hot off the press, warm maybe at this point.
Yes,
One of the things I think is exciting is we titled the book "BariEducated" and capitalized the ED in the middle because that's the
love it.
acronym for eating disorders, and so we're wanting to
Yes,
educate integrative health professionals about the entire bariatric journey. And then there's heavy focus on treating patients that have eating disorders. And so what we find in professional world is you get really connected with your team. You're building a lot of rapport, maybe with your bariatric dietitian, the therapist that did the pre-op evaluation. And then maybe 2 to 3 years out from surgery, that patient is feeling somewhat of a loss of control with some eating habits or struggling with some weight regain. And if that bariatric professional doesn't have any experience with eating disorders, then they send them to a different treatment team, which is ethical and appropriate. But a lot of people don't want to leave their support network because they have such good rapport. So we
right.
want bariatric professionals to be more educated in how to treat the eating disorder piece. And then we also want, if you have an eating disorder treatment team, for them to have knowledge about, hey, what vitamins did this population need? Or some of the behaviors like cutting your food into really small bites or not drinking with your meal or choosing lower carbs on your plate can be seen as eating disorder behavior from eating disorder professionals, but they're actually good bariatric guidelines. So we want bariatric professionals to be more educated in eating disorder treatment, and then we want eating disorder professionals to be more educated in the bariatric guidelines, and everything that comes with it therapeutically. So that
I
was our
love
intention.
I love that. That is so, so brilliant. So that I'm sure you will have the book available at ASMBS this year.
We did. We did.
Uh-huh.
Yeah.
Oh, you
Yeah.
already
That was
did at the one this past year. And
Yeah,
yeah.
we
Yeah.
had it in
Yeah, that
Vegas
was
this
our kind
summer.
of our first launch of it was at the bookstore there.
Yay! Good, good, good. Are you guys involved with the International Federation? If so, no?
No,
Well,
no.
you're going to be. I'm going to give you some good connections there.
Yeah,
Awesome.
thank you.
The new president of the allied health portion for IFSO, the international, is a very good friend of mine.
Oh,
That's
cool.
great.
That's
So we
awesome.
will get that book there because it needs to be there. Yeah, yeah,
That'd be
very
great.
good. And I think that's a wonderful because I think eating disorder treatment and eating disorders are really left out of the bariatric care team almost completely.
Yeah, we've been doing a lot of presenting, kind of in conjunction with, the release of the book. We presented
Oh,
at ASMBS on
yeah,
eating disorders, and people have just really, I mean, the response has been overwhelming. They're like, we need to know this. We don't know this. We want to learn more and understand more
absolutely.
because they're seeing it. If you practice and see these
Right.
patients, you're definitely seeing disordered eating or eating disorders.
And I really love the combination of you guys, your registered dietitian and your therapy skills together, because it's all so truly so intertwined and integrated. And I don't know that a lot of the bariatric programs, although we have integrated healthcare or we have a multidisciplinary treatment team, a lot of the team is very segregated. A lot of us work at home, a lot of people aren't even in the office. So I think that doing that education for offices is great and also for patients because patients don't know the difference between, do I have an eating disorder, or do I have obesity, or do I have food addiction, or do I have, what the heck do I have?
Right.
So patients are confused as well as professionals.
Hmm.
So since we're kind of catering to patients in the podcast, what are some things that, just off the top of your head, some things that come to your mind that you would like patients to be educated about?
Oh, wow. That's a big, big one
That is a
in
big
terms
one.
of eating disorder. So I
Yeah.
think one of the things is a lot of times patients have had disordered eating or an eating disorder for a long time and not realized it. And I think, we know that patients in higher weight bodies are often missed because of weight bias. And so, you know, I've had people say, "Oh, I don't have an eating disorder. I just can't stop eating." I'm like, "Well, that kind of is an eating disorder behavior."
Well,
Um,
yes, it's certainly
that they've just
disordered
never
eating.
been identified. And sometimes it's just a relief to them to know, like,
I agree.
there's a name for this and there's treatment for it, and
Yes.
we can get you help.
I know for me personally, it was a huge relief. It was a
Hmm.
huge relief to understand that, oh, I'm not the only one starving myself to death. And I was on a college campus, so clearly I was not the only girl on campus starving myself to death.
Right.
And thank God, even back then, they had counseling on campus, and
Hmm.
they had people specializing in eating disorders. So, can you describe the major eating disorders and what you see most in the bariatric population?
Yeah, so one of the behaviors that I think we see a lot is just loss of control with eating. And I think that it can be really hard to recognize that after surgery because it looks so different. And if you're comparing that to pre op behaviors, it can be so minimal in terms of volume consumed or maybe even what the choice is that it's really hard to identify that loss of control eating. It's real a feeling that people have in their heart or just a consciousness in their mind that I'm not in control of my behaviors. I'm not in control of my choices. And my advice is talk about it and ask for help. Reach out to your support system, kind of sort through some of those things and figure out what's driving some of that behavior, what's the underlying root of that behavior, and then some behavioral strategies if it's setting up things in your environment or related to mindfulness and your eating behaviors, even revisiting just the bariatric basics on how to stay focused and or get back on track. But just understanding that is really complicated. Identifying it, understanding it. I think a message I would like to send to viewers is just that there is so much hope out there, with the right treatment team that's knowledgeable and your own patience and kind of discipline and commitment to your program that there's so much hope that you can get to a place of freedom and freedom from dieting and freedom from weight obsession and being able to treat your body with nourishing foods and feel well without being obsessed with dieting but still caring and making very conscious decisions about your health. So kind of blending your first question and second together is I think loss of control is a major eating disorder behavior, but I just want to share there's so much hope for asking for help and having the courage to do so that you can live a life that is full and be part of food focused situations and food focused gatherings but still take responsibility for your own health. You can balance those two with help.
And another thing related to the loss of control and other symptoms associated with whether it be an eating disorder, food addiction, whatever a person wants to classify it as, is that loss of control behavior, that one criteria, if you will, has a lot of behavioral interventions that
Hmm.
you can do. So what off the top of your head? I mean, I really stress on keeping your home. I'll give you some time to think about that. Some of those tips that you give people for the loss of control, but I really focus a lot, and you mentioned the home environment. Keeping your home a safe haven. That
Hmm.
should be one of your absolute safe places, as free of triggers as possible. So, what kinds of behavioral tips do you generally give people for dealing with that loss of control? Because a lot of that nighttime eating, people feel loss of control over that
Hmm.
nighttime eating thing.
Yeah, I think the environment is important. I tell people, if you were a recovering alcoholic, you wouldn't have your favorite bottle of wine sitting out on the counter, but then they live maybe in an environment where somebody's bringing in, food that's very triggering for them, or they're bringing it in. So, I mean, environmental control is part of it, but then also just that emotional awareness. So obviously, as a therapist, that's my jam. But really having them identify, what feelings or conflicts or situations are happening that are spurring emotional eating or eating in the absence of hunger. I know, is it like every time I'm angry, I'm grabbing for this, or when I'm sad, and a lot of times there's this mindless kind of autopilot feel to it. So they may not really be in touch with that. And so food records, are a really good way to do that. And when we prescribe food records, we do it in a way that's not just focused on, the calories and the macronutrients. We want to know what's going on environmentally, and we use more CBT focused food records.
Absolutely,
Um,
yeah.
so you
What was
can
the
really understand.
situation? What were the thoughts? Are those thoughts realistic? How can you counter those thoughts? That's great, great information.
Mhm.
Yeah, and what saddens me is that a lot of professionals in the bariatric space do not know those things. They don't know to, prescribe those kinds of things. So the aftercare, that's my whole jam, right?
Yep.
This
Yeah.
very aftercare is so critical, and so because in the pre-surgical process, there's no education about, challenging your thoughts or identifying your emotions and doing that really nice, beautiful, detailed food journal that includes not just what you ate in the macros, but what was happening in the situation. How did you feel in that situation? What were your thoughts? And doing some emotional regulation and all that good stuff. The other thing is, and this is where I think our work with patients is so critical. I think patients going into surgery, and rightly so, totally understand this from a patient perspective, is they just want that weight off. They
Mhm.
just want that weight off. And I think, like, you mentioned, Chandra, 2 to 3 years out, it's like, whoa, what's going on? I'm having some struggle. This didn't fix it all like I had hoped it
Mhm.
would. And I think it's hard for patients to get into or seek help from people to do this deeper work. I've had people say to me so many times, Connie, people don't want what you're selling. Well, there are enough people out there who do, I hope, because the deeper work is so necessary. And Chandra, from your perspective as a dietitian, how do you feel that the whole dietitian world is when it comes to preparation for working with the feelings and the emotions and the putting it
Mhm.
all together? Because a lot of dietitians are going to go, let's look at your food. Let's look at your food.
Yeah, I think there is a lot of focus on that, and that's one of the reasons why I even appreciate collaborating with Kelly so much. Is I do think we have to communicate back and forth, and I do believe that there is a gray area sometimes professionally in our boundaries on things that we're checking in about, but
Mhm.
we have to know kind of where our boundary is. So if someone's sharing something with me that is just maybe some emotional turmoil, I might let them share that story just a little bit. And then my job is to kind of change that subject to, and how do you recognize that that's impacting your food choices? And then I go to Kelly and say, hey, this person's really been having a hard time lately. I just want to give you a heads up, because sometimes they might be likely to not bring that up in a therapy session because it's safer to bring up in a nutrition session, knowing that I'm not going to go deeper with that or ask too many questions. And it's so helpful to collaborate with somebody. So if Kelly's, doing deeper work and if it's something with journaling or exploring trauma from the past, then she might say, hey, I want to give you a heads up. You might notice some things in that person's eating. And so then they came to me and say, hey, I've been doing so much better, but now I'm really tempted to restrict, or I've vomited a couple times, or I'm feeling a loss of control. I can really normalize that behavior. And it makes sense to me because Kelly has shared that you've been pushing yourself more in therapy. So to normalize that instead of just thinking we're taking 5 steps back, it's so valuable to understand the correlation between eating and emotions. I think that's something that just I've been sensitive to in my own heart more than something that I've learned. Some continuing ed has certainly taught me to be more aware of that, but just really working with Kelly, working with your integrative health team is so essential to understand how, when someone's doing better nutritionally, they might struggle more than with feeling more intense, which is progress and healing, but they might not recognize it as that. So yeah, the relationship is so important to communicate. And there's definitely gray areas on what we check in about, but knowing, where you stop that conversation and turn it to your area of expertise.
And I think one of the things too that, and we've had a lot of comments about it when we've presented at conferences, is the amount of time you get to spend with the patient. So sometimes dietitian visits are really, depending on the setting, if it's a medical setting or hospital, they're really short. And
Mm,
Chandra spends more, a lot more time with
that's
patients
awesome.
than kind of typical, if you're depending on your setting. But I think that makes a big difference in terms of developing that rapport, and then also just the information you're gathering and giving. So
Absolutely.
that time is
Yeah.
beautiful.
Speaking of which, pre-surgical evaluations, when I started doing them, and I also came into the field through the alcohol and, addiction and recovery field. And so
Mhm.
I was very aware of the critical nature of that aftercare component because I've been in recovery for 35 years. And I was really young, I guess, relatively speaking, when I got into recovery. And so it's been a long time, but I know that without that aftercare piece and learning to live
Mhm.
without turning to, well, started with the eating disorder, right? And then it just kind of escalated into other behaviors. But without having that long-term aftercare education, it was through therapy, but it was
Mhm.
education about communication skills,
Mhm.
education about being able to work through conflict. Conflict has such a bad rap for people,
Right.
right? They think it's gonna be big blow up, blah, blah. Doesn't have to be. It's just learning to use assertive communication, and regulate your emotions. And so without all of those kinds of skills learned after quit using the food in the way you were or the alcohol or whatever it happened to be, I don't know that I would have stood a chance in terms
Right.
of following on the road to recovery. And I
Mhm.
call what the work that I do recovering from the disease of obesity or
Mhm.
recovering from an eating disorder or recovering from whatever. And so you guys work with patients as a team, not always, I'm sure, but when the need is there.
Yes.
And we do bring a lot of these just pieces of conversation up preoperatively, although I don't think the patient is usually maybe ready to hear them or isn't capable of truly
Yes,
comprehending and understanding how much their relationship with food, their relationship with their partner, their relationship with friends, how much holidays can be different until they're in that chapter, until they're in that piece. But because we mention it preoperatively, I think they're more comfortable to be like, hey, I recall them talking about that, so they're more likely to come to aftercare
yes.
sessions or support groups with us and talk about those things because we kind of give them a heads up. So
I
they
think
know
that's
that it's normal to
critical,
struggle then afterwards or normal to need to work through some of these things.
which
Yeah, I
is
have
why
a patient that always says the surgery changed my stomach, it didn't change my brain. And so,
absolutely,
and her brother is long term in recovery from alcohol. And she's like, I feel like this is the same journey, just in a different setting, right?
and
That she
I
needs that
yeah,
support and accountability ongoing
yeah,
because, she doesn't want to relapse with her eating disorder. And I think that's a big thing. Like having an eating disorder, you want to have it ideally under control prior to surgery. That's not always
sure,
caught or happening, but and then afterwards, if you've had an eating disorder history, I think it's very important that you are involved in aftercare because you're more vulnerable to relapse. And initially you're on that pink cloud and everything's great and you're losing weight and feeling good and looking good, but then kind of it goes back to reality and this is your new
right.
norm, and how do you sustain that? And I think that support for ongoing, eating disorder relapse prevention or working through little slips that you have is so crucial.
Absolutely, and, relapse prevention, like you said, I think those are critical, and I use the term personal prevention plan.
Mm-hmm.
No, actually, no, I don't. I use personal protection plan. It's like you wanna protect yourself from those situations, holidays, really, and grocery store and office events and whatever it is. You wanna protect yourself from falling into the relapse behavior, and so, sounds like we're doing a lot of the same work.
Yeah.
But speaking of, educating people ahead of time, that's why I was so sad when that the guy who was doing all that pre-surgical stuff couldn't sustain that because people weren't gonna pay for that when they could go elsewhere. and not get that. And I agree that patients sometimes aren't aware of that, the need for that ahead of time, nor do they care. They just want that weight off. But I
Right.
love the idea of planting those seeds. So part of what I do in my work is years ago, probably 2 years after I started in the field, I made a series of videos that I require them to watch as part of the pre-surgical evaluation process. And I can't tell you, I mean, they moan and groan about it because it's more time. But then they come back and they're like, I had never thought of it in that term. I had never thought of a relationship with food. I had never thought of how this impacts my relationship with my partner, my children, my coworkers, my family. And so it's great to have that pre surgical, even if it is just the planting of those seeds, so they can say, oh, I remember hearing that. So I'm so
Right.
excited to hear that you guys do that. Are you going to come with
Yeah.
a book for the patients next? I hope.
We
Girls,
don't have enough
for three
amnesia
years.
about the writing process of this one, but it's definitely been asked more than once for a resource for the patient. So stay
Absolutely,
tuned.
absolutely. So I'm thinking that you could probably like, do you go to a lot of the patient events, the OAC or you know, uh,
We've just done a lot more on the professional side
okay,
of conferences and speaking to integrated health folks.
good, good,
So
good.
I've written for OAC
I
and
saw that in your bio. Yeah, yeah.
spoken.
People,
So yeah.
anybody who doesn't know, OAC is Obesity Action Coalition, and they work a lot with the stigma and trying to get
Mhm.
legislation passed, and they do a lot of really, really good work.
Yeah, it's a tremendous organization. So
Yeah, absolutely. So we need to get you at If So, the various If So events. So we'll all go. Here's what we'll do. We'll go to Melbourne together this year
oh well,
in
twist our
2024.
arm.
Yeah, we're in Melbourne. That's where If So's happening this year. Um, yeah, so patients. Let's talk about specific eating disorders.
Sure.
So let's start with anorexia.
Okay.
That,
It's the most rare post-operative eating disorder, but what we do see more and more, and it gets missed whether you've had bariatric surgery or not, is atypical anorexia, where the person does not meet the weight criteria for anorexia, but they have all the other symptoms and behaviors and fears. And their labs and medically, they can be just as sick as somebody who's at a very low weight. So I think that's a very important distinction. You can be anorexic without being in a very low weight body. But traditional anorexia, we've seen very rarely in the 20 years that we've collaborated. But
well,
it does happen, and it's very dangerous because of refeeding and the whole process. So it usually requires a higher level of care than just outpatient.
so since we're just talking about educating people, what are the
Mhm.
typical criteria or the typical, what would you see in
Mhm.
somebody who has anorexia?
Extreme restriction of food intake, and obviously you have to consider the bariatric guidelines. We're looking at it being, well below what's
Right,
normal for a bariatric
right,
patient. They're not getting in enough, calories or protein or fluids. Extreme fear of weight gain. Even, kind of this distorted view of themselves. So they think they're fat when they're not. Again, with atypical anorexia, that's a little bit different, but just not seeing themselves as they are, that really distorted body image. Um, and, just that really pervasive, phobia of, eating and gaining weight and
right.
missing anything.
No, just to elaborate from a patient perspective, is it is so normal post bariatric surgery to be afraid of regaining weight, and
Right,
I want to normalize that. But we're talking about to the degree that it's impacting your quality of life. So
Mhm.
right.
it's impacting your health, it's impacting the ability to go eat socially, just intense phobia, intense fear. So some of that is a little bit normal. That doesn't mean you have an
Yes.
eating disorder, but when you really feel just terrified, you need help working through how to navigate this buffet, or choices to make that really help you maintain a healthy body weight, so that you're able to let go of that fear of regain, so that you can also live a life in line with your values of other things that are important to you too.
I love your language. I love your language so much, and I love the work you're doing. But I love that if you're not living according to your values, that's a
Mhm.
good indicator that something's off, right? And I also love, like, and I agree that there's not a lot of anorexia after bariatric surgery, but I think it's important for people just to know what it is. And I'm
Oh
also
yeah, absolutely.
glad you normalized that fear of regain. Fear of regain is ubiquitous, right? I don't know very many patients who've had weight loss surgery who aren't afraid of regain because it's been such a cyclical thing for
Yeah.
them.
I
And
think
but
a
I
good thing to compare to is, I think of growing up, I had fear of my third grade teacher, and I also had fear of my dad. But to me, it was a degree of respect. I wasn't afraid to go to school, and I wasn't afraid of my father. I didn't live in fear of him, but I had fear of what he could do. And my comparison to that is being respectful of maybe your surgeon and what they were willing to do for you, and respectful of your own body and how you're taking care of it. So it's normal to have fear, but we don't want you to live in fear of. And if you are, we want you to get help and talk about it and work through some of those things.
That is brilliant.
She's the analogy queen.
That is a really great analogy. I love that.
And
I
one thing I would say too is that sometimes somebody is, a post-op patient that gets praised as like the poster child, like, and they
oh
might be
gosh,
a quote unquote normal weight for their height, but they're
right,
not a normal weight for them as a bariatric patient. So they've lost way more than what we would expect. And so
exactly.
even though they're in a quote unquote normal size body, what they're doing to get there is not normal. And
Yeah,
again, that degree of impairment and distress is the factor that sets it
yeah,
apart. But they're going to get reinforced from the outside world, including
that's
sometimes from the
right.
medical team, like, oh,
Oh,
you've lost your weight and
absolutely.
kept it off and look so great, and you're exercising all the time. That's wonderful.
All the time, like 5 hours a day, a little extreme. Yeah. I recently was in a social situation and I had a patient. I was just visiting, chatting, so it wasn't a professional situation at all, but it pinged my ear because here's what I heard her say. She got down to this weight and she liked it. And she thought, well, what if I get down to this weight and see what
Mhm.
that feels like? And I got there. And then I thought, well, I'm like, oh, ding, 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 ding.
Mhm.
Those are red flags
Yeah.
for that anorexic mindset.
Yep.
How low can I
Exactly.
go? How low can I go? How low can I go? So that's something to be aware of. So, what's the eating disorder that falls into the purview of eating disorders that you see most commonly after bariatric surgery?
So I would say binge eating disorder, but we kind of look at it, there's a lot of differences in kind of traditional binge eating versus bariatric binging. So somebody
Right.
might kind of graze binge versus have a really high volume, high calorie amount of food. And Chandra can speak more to that in terms of what she's seen with patients. But again, that loss of control and then just the secrecy and shame involved in the behavior and the hiding and sneaking and not even wanting to tell anyone what you're having kind of behind closed doors. You might eat one way in public and another way by
Sure.
yourself. Anything you want to say about baking? um, and so a lot of times patients are most familiar with that because they may have struggled. That's the most common preoperative eating disorder as well. And that really there's a lot tied in with emotions and there's a huge correlation between binge eating and trauma. So we know that folks with binge eating disorder have a very high rate of mainly childhood trauma, but also
Right.
other traumas. I mean,
Right.
I treat a ton of complex PTSD
Yes.
post-operatively. So,
Absolutely. And that's another thing patients don't want to deal with, right? I mean, when they do deal with it, they're so grateful that they did. But I
mhm.
call that, it's shoved in your emotional closet. You're standing in front of that sucker like I don't want anything to eke out of there because it's scary and painful.
And
And
that
so
that weight could really have been a protective mechanism. So,
absolutely.
when that starts to come off, what happens, trauma symptom wise,
Right.
um, you know, is
Are you guys familiar
significant.
with this article? It's written by a bunch of physicians from Kaiser who did a, a ginormous study, but it's called obesity, problem, solution, or both.
Hmm.
It's a really great article. And I've presented just using the information from that article at a lot of conferences because it's something that a lot of people in the professional world really need to understand because these doctors like, we didn't understand the first thing about obesity. We thought we understood it from the
Right.
medical perspective, but they had no idea of the emotional entanglement and
Oh
the
yes,
trauma.
it's a metabolic disease, but also can have a lot of neurological, psychological, you know,
Without a doubt.
underpinnings. Yeah.
Without a doubt. And that's why it takes that whole treatment team
Hmm.
to treat it. So what are the criteria, or how would you define binge eating disorder?
So the loss of control eating more than is normal for a bariatric patient. So again, that can look different for different people, and that could be kind of that cumulative effect of the graze binging. Some people can eat large amounts, and again, just that secrecy and shame and distress about what they're eating.
Right,
But
that
they're
emotional
not doing
distress.
anything to compensate for the binging because that goes into bulimia, which we can talk about in a minute.
Right.
So they're just having the binge behavior, but not doing anything compensatory to.
So can you describe, because I know people are going to ask me, what do they mean by graze binging?
Yeah, so sometimes, depending on the surgery somebody had, just the size of their pouch, they might not be able to binge to a degree that I want to call it comfortable, uncomfortable for them. And so they might just find themselves like picking and grazing throughout the day. So that could be, eating an entire bag of goldfish. And I don't know exactly what that is, but maybe that's 1,000 calories. And they've ate that over the course of 3 or 4 hours. That's binge grazing. And so it's very mindless. It's not a planned snack. They might be doing it at work while they're multitasking or, doing it to kind of comfort themselves, or they're just used to having flavor in their mouth, or to procrastinate, or because they're feeling anxious or stressed. And so that's not a classic binge where they're sitting down and eating a large volume of food in a short period of time, but just kind of grazing on cookies throughout the evening, or grazing on larger volumes of pretzels. And so a binge isn't defined by the portion size, or it's not defined by the calories, but just kind of general common sense of, is it a larger amount of food than is normal for a bariatric patient? So
Yeah.
it's hard to recognize because there's not a clear line on defining it.
Absolutely, but it makes so much sense, and I really want patients to understand that
Mhm.
because you mentioned the bariatric basics initially, and for a lot of people, the dietitian will tell them you eat this many hours apart or this many, you have a protocol, and
Mhm.
so that protocol doesn't include, snacking between those number of hours. And so reminding people about those bariatric basics. I went on a girls trip with a good friend of mine recently, and we had a little condo kind of place, and she left a bag of whatever it was sitting on the counter, and every time she walked by, I'm like, in my head, of course, I'm thinking, geez, that's how you accumulate a whole lot of calories without having any idea about it.
Yeah, it's
And
just kind of mindless and
not
Yes.
always, but a lot of times those tend to be carbohydrate rich
Oh,
soft calories. And so they're
yeah,
more comfortable to fit into the pouch.
absolutely. They just slide on in there, right?
we also see where people really, kind of do well with following the bariatric guidelines during the day. Then they're,
Yes.
kind of that release at night, like, oh, I'm home, work is over, the kids are in bed. Now this is my time. And they overeat, a majority of their calories in the nighttime after kind of following what they're supposed to during the daytime, kind of, and I hate to say they think of it as being good, and then they,
Yeah.
are
Yeah. Yeah.
bad at night.
Right.
It's more just kind of reactionary of, whether it's
Right.
emotional or if they didn't eat enough during the day or didn't get enough protein in or what,
Nutrition.
your
Right.
body's seeking out that food, but they're not doing it in kind of
And
a.
again, oftentimes at night, it's not those nutrition dense foods that they're
Mhm.
seeking. So
Right.
their body's still hungry for the
Yeah.
food that it needs. Yeah. And so again, back to the environment and how important that is and being mindful.
Hmm.
Is this just a habit you've accrued, or are you, when you're alone and it's quiet, uncomfortable with yourself and what's going on in there? And yeah, it's very multi layered.
Yes,
And
definitely.
so dealing with
Honey, you
all of
asked
that.
something. What's really valuable when patients feel out of control? What can they do? And I think pre-planning is so important, but way beyond pre-planning of traditional meal planning. Like, what am I going to have this week? And let me make a grocery shopping list. But what's your plan when you don't feel like following through? What's your
That's right.
plan
Your
Plan
backup
B.
plan to your
when
plan.
your neighbor brings over a tray of holiday cookies and they want to do an exchange? Like, what's your
Yeah,
plan during these things that are really tempting and triggering and normal traditions, maybe? Like, what's your plan then? And let's work through that together. I think
I
that's
love
so
that.
important to have a plan A and kind of a backup plan. So, what if
I
plan
love
A is
that.
I'm having a small bag of popcorn tonight,
Right.
but then your kid ate it, or it now doesn't sound good. So, what's your plan going to be? Because we don't want plan B to be screw it, I don't care.
Exactly. Oh gosh, I love it. Ooh, I'm moving there and we'll work together. No, I can't. My grandkids are here. Never mind. Okay. Well, you do all that great work here. I'll do the great work here and we'll just get more people in the fold. Okay. So here I have a question for you because I do a lot of pre-surgical evaluations. And I know from the conferences that binge eating disorder is supposedly part of 50% of our patients pre-surgical. People don't tell me about it. I ask, they don't tell me.
Mhm. Yeah, I think it's, how are you asking, what kind of questions, but sometimes, I mean, obviously people can be not fully disclosing in a pre-op evaluation because they're, there for an evaluative process and they're worried about what the outcome's going to be. But
Absolutely.
also I think sometimes just not having insight into what that looks like,
Right.
especially if they've been higher weight all their life and someone's just been like, oh, you should be on a diet. And they think like this whole yo yo cycle is normal, or, being really, restrictive or having good foods, bad foods. They might not even, they honestly may not realize. So, kind of,
Absolutely.
you have to ask about the behaviors rather than,
So let's pretend we're doing an eval and you're asking me the questions because this will help me and it will help the
Mhm.
patients. So, what kinds of questions might you ask to get to that binge eating kinds of?
Sure. I mean, definitely about, eating in the absence of hunger, eating, related to emotions, eating more than you wanted to or planned to. But I also just have them I try to get them to paint a picture for me. So I'll say, what's a typical day for you eating wise? Of course, they're going to tell you kind of their best typical day.
I know.
But
I'm
then
like,
I'll
right
say,
now.
tell me everything you've eaten in the past, 24 to 48
Yeah.
hours.
Right.
Um, and then, kind of asking about sneak eating or, um, hiding food or, lying about what you're eating, those kind of things, just kind of more nuanced questions that,
Right.
then they kind of start to realize, okay, this person kind of gets it.
Yeah.
Um,
Exactly. And like you said, what's your public eating behavior versus your private
mhm.
eating behavior? And how do you feel when you're eating? Those kinds of things and the loss of control sorts of things. Yeah, that makes good sense.
I also
Um,
think it's so valuable to reassure clients that we're on their team,
Mhm.
because I think the
Absolutely.
default is coming into an appointment. We have something they want, approval to get surgery, and they want surgery yesterday, and they're willing to say whatever they need to say to get approved for surgery because that's the immediate goal.
Exactly.
But to even be honest with them on it, the more honest you are with me, the better I can help you, the better, the more handouts I can give you, the more knowledge, the more that I can help you preoperatively and postoperatively. But I want to help you succeed. I don't want to just help you get surgery. I want to help you succeed. And I think if there's an
Yeah,
understanding of that, they might be more likely to acknowledge somewhere they're struggling without
exactly.
fear that then they're not going to get surgery, because that's terrible.
Exactly.
If they're honest, then they're not going to get surgery is their fear. And I understand that. So you're going to
Absolutely.
get surgery, maybe not yesterday or tomorrow, but even if
Yes.
it's 3 months or 6 months, I'm going to help you get there. But I
Yes.
want to help you maintain and maximize your weight loss too.
Absolutely. That's what I tell people. I'm not saying this to, you know, to deter you or to, make you feel bad. I want you to be long-term successful. So let's work together so that we can cultivate that and get you to the surgery when it's the best time for you to have surgery.
Yeah, we want to set them up for success. And so
Absolutely.
again, I think that's important, kind of that reassuring, the more honest you are with me, the more I can help
Yes.
you. Yeah.
Right. Yeah, and to reassure them, we want to help them get to the surgery that they clearly need for their health, you know? And I do think that they're so much more likely to be, open and honest when they know you're on their side. Like, "I'm not
Mhm.
trying to prevent you from having this surgery. I want you to have this surgery and have long-term success."
And I think also just emphasizing to patients, the gravity, like there's no other surgery that's going to change your life as quickly other than, maybe gender
Right.
reassignment or a C-section. Like, you're going to wake up
C-section.
and everything is completely different. And then,
Yeah,
6 months down the line, your body is completely different. It's, kind of
right.
unrecognizable to you. There's a lot of head games that go into that.
Yes. So a little segue on that, because the body changes so quickly and the mind struggles and people go
Mhm.
into the store and still pick up the 3X, but they're really in a medium,
Right.
right? A lot of people, I hear this, and it was interesting because before the pandemic and a lot of that social media explosion with the bariatric patients, I didn't hear the term body dysmorphic disorder floating around a lot. But since the pandemic, I hear that, thrown out there a lot. So I've done a lot of uh, support groups at different programs and spoken at conferences about what body dysmorphia is and what it isn't, because what
Mhm.
most people are describing is distorted body
Right,
image
right.
as
Yeah.
opposed to body dysmorphia.
Right. Yeah, that's, a clinical term that is much more rare than how people are utilizing it
Yes,
kind of in the lay sense of it.
right.
And but body image distortion is a normal part of the process because
Sure.
you're losing weight quicker than your mind can keep up with. And
Yeah,
also if you've been in a larger body your entire life, most of these folks, that then to be kind of, quote, a normal size, that like they
right.
just don't even have a perception of, they'll think like, oh, I won't fit in something, like a booth or something. And then they're like, oh, I did easily. Or, they
Yeah.
just don't have a sense of what they actually look like and what space they take up anymore.
And I think it's important for the patients and the professionals to understand the difference between this is an eating disorder, that's not. This is body dysmorphia, this is distorted body image. They're very, very different things. And that's why I'm so glad you're starting with the professionals, because there are professionals. This one lady said to me, "Yeah, my doctor says I probably have body dysmorphia." I'm like, "No, no, you have distorted body image, which makes perfect sense given what you've just been through."
Right, right. Yeah, social media and just the internet in general, it's a blessing and a curse, and you have to really be a discerning consumer,
Yeah,
and
yeah.
the information out there about eating disorders, it can vary widely. So, making sure you're getting information from really reliable sources and not just TikTok.
And I wish there were more registered dietitians and clinicians in the psychotherapy realm who really understood both eating disorders and bariatric population in general, right? But
Right.
especially with so many post-ops now in the general population. And you'll send them to an RD or you'll send them to a therapist who
Mhm.
has no understanding of the nuances affiliated with this population group. And so, yeah, it can be really scary
Yeah. Yeah, that's part. I mean, that was kind of the whole impetus to write the book.
for sure,
Was that
for
these
sure.
two realms don't really intersect with each other too much. We were kind of unique in that we've done both for so long.
Absolutely. What a great combination
Yeah, when
of
we sent bariatric patients to higher level of care, I'll spend hours on the phone with the dietitian I'm referring to at higher level of care, teaching them about
yes.
vitamins and just some of the basics on portioning their plate and how they might need special accommodations for when they're challenging themselves to a treat or something. And a lot of times they don't follow through with it, and I think they just don't. They're not familiar with it. They're not used to, they don't have the resource maybe to buy the vitamins that they're available. And so I hope that the book makes a difference for giving better quality of care to bariatric patients that need eating disorder treatment.
Absolutely, because that yeah, if you send them to a facility for that higher level of care that they
Yeah,
need, but
they
they
don't
don't
know they shouldn't
understand.
drink with the meal. They think cutting the food up
Yes.
into small bites is eating disorder behavior because it is in an eating disorder world, but the bariatric piece makes that an exception. Or, if somebody
Yes.
doesn't want to eat the whole bagel from Starbucks challenge, it's because it doesn't fit and it's like a sticky dough ball in that pouch. And so there's just so much to teach a referring dietitian when you're about to put your patient in their care. So that, that is what our passion is educating professionals to be more knowledgeable, because we do want to provide better quality care.
And also
Right.
teaching patients to advocate for themselves too.
Yes,
Saying, like, I'm
for
a
sure.
bariatric patient. I have these, and I think sometimes too, people forget what those requirements are. I've had even patients I've worked with long term and they're like, oh yeah, I'm not supposed to do X, Y, or Z, just like a basic, 101 that they just have gotten away from.
Yeah. Yes. So I think those bariatric basics are very critical for everybody. But yeah, then the patients get confused because they're like, well, my dietitian at the bariatric center says this, and the one at the eating disorder place says this, and the one at the hospital said that.
Right.
And
And
then they're
so,
in that same position of pre-op of the trainer told me to do this, Weight Watchers told me to do this, and just the
yes,
overabundance of information or misinformation is so
yes.
confusing. So
So what I want to tell the listeners is that if you've had bariatric surgery, you are now and forevermore a bariatric patient.
Mhm.
And you need professionals who specialize and have the knowledge of working with bariatric patients, because
Mhm.
it is a very specialized field. And I know that for the patients, for you listeners, it can be very difficult to try to educate the professional, because a lot of times you've been taught to respect them and, not whatever, whatever. But do learn to advocate for yourself. Find a mentor who's been out in, living their best bariatric life
Mhm.
for a while, who can kind of encourage you and maybe even role play with you about seeing a provider and preparing you to do that, because you are your best advocate. And we can, as patients, teach our providers things as well, or
Yeah,
maybe just hand them
absolutely.
a pamphlet or something, or give them that book, Very Educated, as a gift. This is for your entire
Stocking
life.
stuffer.
And these ladies will come in and do continuing education with you. Clearly, you need it. So let's talk about bulimia real briefly here.
So bulimia, we do see this post-operatively, and I think it can get confusing because people sometimes get sick or throw up after surgery for a
Right.
variety of reasons. Chandra can go more into that, but it's where you're eating inappropriately, eating either larger amounts or foods that kind of don't fit in that bariatric realm, and then doing something to compensate for it. We most commonly think of purging via self-induced vomiting, but you could be, using laxatives or diuretics. You could be, compulsively exercising. Again, that's something that often gets praised by, oh, you're a bariatric patient, you're doing, so much to exercise and keep your weight under control. It's like that, again, is it impairing your functioning, and what's it doing to you psychologically? And so the big piece of that is the loss of control eating plus the compensatory behavior. And I'm going to let you talk about unplugging versus purging.
Yeah, so the
Oh,
huge difference between if you're especially newer out from surgery and you're still learning what size bite is comfortable to chew and swallow and fit in your stomach, and what food textures are tolerated better in your stomach. If you're kind of feeling that plugging feeling where some of the food is stuck, maybe
yeah.
it's dry chicken or a piece of bread that you've not toasted, or you've taken too big of a bite of a piece of toast, and that feels stuck and that causes you to vomit, that is not disordered eating behavior. That is extremely normal to learn post-operatively. Hopefully you learn your lesson first, after several months, and it happens less and less frequently, but then every now and then it pops up. You're at a social gathering and you're chit-chatting with a friend and you ate too fast, and it happens again, and that's normal. It's a normal part of the bariatric journey. Where it becomes eating disordered is when you're binging and you're not kind of learning your lesson in terms of, oh, I really need to slow down, or I need to make sure that chicken is more moist, or I need to, stay away from bagels for a little while and I'll try it again to introduce it again later once I'm farther out. And if you're using it as a form of coping, so if it is a form of, a release for you, if it's a stress reliever, if it's avoiding something, and that's something that you'll work through with a therapist. But if there's a coping mechanism function behind it, but in your mind, your intention is to compensate for the calories that you consumed, and you're doing it on purpose. Your intention is, I'm going to eat this bagel because it's comforting and I love it, and I know that I'm going to throw it up. That's disordered eating behavior, and it's incredibly dangerous. incredibly dangerous, throws off your electrolytes, can dehydrate you. You know, it's already hard to get all of your nutrients in as a post-op bariatric patient. And so when you're compensating through vomiting or abusing laxatives, it just makes it even harder to live your best life and live quality. And then restriction is the other thing that people really compensate with. Sometimes that can be misidentified as bulimia. So if you're compensating by skipping meals the next day because you're not okay with what you put in your mouth the night before, you're purposely compensating calories that you consumed. And that really keeps a cycle going of binging and restricting and binging and restricting. Because then you're starving at 3 o'clock in the afternoon. And when we're starving, then we tend to be more impulsive with our food choices, eat really quickly, and then we're uncomfortable again. And so then you maybe want to purge that. And so a regular pattern of eating is what is so valuable if you're finding yourself in that cycle at all. That if you eat something that you're not comfortable with, you feel a loss of control, you made a food choice that, you know, this doesn't feel too good, the very next meal, the very next snack, get right back on track with what your original plan was to really break that cycle of that purging and restricting, or the, you know, the binging and the purging.
And I think one distinction too is that sometimes with binge eating disorder, the food feels more addictive, but with bulimia, the behaviors feel more addictive.
Oh, that's a great
Um,
distinction. That's a
yeah,
great
not
distinction.
always, but that's kind of one way we conceptualize the difference too, is that, you
Yeah.
know, they're more addicted to that release from, you know,
Yes.
running 10 miles or, you know,
Right.
throwing up or whatever they're doing.
Yeah. And if you're listening and you don't understand what, you know, we're meaning by the release, it's like if you force yourself to throw up, or if you exercise to an extreme, you're just trying to relieve yourself from some intense emotions or an intense feeling like you've got to get rid of something. So that's kind of, and I love that distinction. Can you say it one more time
Sure.
between?
So it's kind of the difference can be, yeah, with binge eating disorder, patients will describe feeling addicted to the food, whereas with bulimia, they feel more addicted to the behavior. So, you know,
I
the
love it.
sometimes even just the preparing for a binge and that, you know, planning out what
Yes.
they're going to have, you know, and like
Yes.
seeking it out and, you know, going through multiple drive-throughs or whatever, that
Yes.
gives them that thrill or that rush.
Yeah.
You know, I have
Yeah.
a client that is very big into sneak eating, and she's like, if that food was just right in front of me and I didn't have to sneak it, it wouldn't have the same allure.
Right.
It
Right.
almost feels like an affair
Yeah.
to me. The
Yes.
sneakiness
Yes.
of it, the planning, this, yeah.
And you know, I come from the field of addiction and recovery, and
Mhm.
that's also a big part of, you know, like in the field of sex addiction. It's not the, you know, the act itself. It's that adrenaline rush of sneaking it, you know, preparing, and
Mhm.
it's all of that. And so I know it's got to be extraordinarily confusing for patients. It's like, my God, is this an eating disorder? Is it a food addiction? Or is it, you know, just, you know, that food noise? Or what? Does it really matter? What matters is that you get the help that you need to quiet
Absolutely.
that noise, to learn the behaviors, to get the mindfulness involved in your life, to get the nutrition that your body actually needs. So call it a bad habit, call it an eating disorder, call it a food addiction. If you're confused, it doesn't matter. Get the help you need. Right?
Absolutely. Yeah. And if you're having to ask yourself those questions, like, is this like,
Yes.
if you're asking that, it's likely, you know,
Yes.
somewhere in your heart or intuitively, like, this is not right. This isn't aligning with my values, or this is impairing me in some way. You know, if you're even questioning, well, which disorder do I have? Well,
Right. I always say if it's a problem, it's a problem.
yep.
Who cares what we call it? Let's work on
What's it? Yeah.
getting you a place where you have where you're more at peace with this food thing. And from my own personal experience and from talking to a lot of other people, I think it's important to help patients understand that the draw to whatever you've used as a coping or whatever may not go away ever. Like that anorexic tendency of mine in my head, it's never as bad, but it's never completely gone either. So it's not about thinking, oh, I'll get over this and it'll be gone for the rest of my life.
Right.
It may, but it may not. That tendency to be like, oh God, I just ate. I feel antsy, right?
Mhm.
Learning the skills to go, I ate a healthy food? I ate it in healthy portions. Is this in alignment with my values? Working through that, using the skills you learn from the dietitian and the therapist to not let it get the best of you and take over
Right.
your life, so it's not interfering in your daily life. But
Yeah, we
sometimes
talk about turning the volume down.
turning
It
the
may not,
volume down.
it may be real quiet in the background, or it may just blip up every once in a while, but ideally you're free from it, but we know
Right.
that that's not always the case, especially if you are kind of wired in an addictive way. The brain wiring is definitely different,
Yes.
that. And
Mhm.
so it's just about how loud are those thoughts, urges,
Yeah.
and kind of triggers.
So
I
we
gave
also
it
set people up with a plan of, if you know that it's going to be a harder season, such as the holidays, or maybe, an aging parent is not doing well, that you're stepping up your level of support too, to keep that
right.
voice quieter in your head.
Right, because as you guys know, and I know, the number one reason people say they regained is life happened or stress. And so
Mhm.
what I say to them is, you're expecting surgery to do something it doesn't do. Surgery doesn't
Right.
teach you how to handle stress. Surgery doesn't keep stress from happening in your life. You can be assured that stress will continue. So, what is important is to learn coping skills for dealing with stress and keeping you on track with the nutritional food that your body actually needs, using the mindfulness and all the tools that are out there. And there is a lot available out there. So, we just all encourage you guys listening to go out there, get the help. The people who are working passionately and compassionately in this field are not going to judge you.
Mhm.
We are here because we know that there's a lot of shame associated with the hiding and the binging and the purging and the secrecy and all that stuff. We know that. And we're not going to judge you for that. We
Right.
get it. It's a part of this overall disease process. And so, find somebody who is compassionate, who will work with you and give you the skills you need to work through these things. And now we have two people here that have a lot of resources that you can turn to. Where can people find you ladies at BariEDucated?
Our website is just www.beeducated.com. So we want people to be very educated.
Mhm.
And then the clinical practice is Chrysalis Center. So that's Chrysalis Center nc.com. And there's resources listed on there as well. And then if you're looking for a provider, there are different kind of databases and search websites that you can go to. The Eating Disorder Alliance is one that I send folks to a lot. They're like, "Oh, I'm in New Jersey. I need to find a eating disorder provider." There are specific websites for to find bariatric providers. So ASMBS is a great resource as well. Find a bariatric therapist.com. They have listings of just people who specialize.
I spent the weekend with Ashlyn,
Oh, okay.
who created that
Yeah,
website just this weekend. She was at my house the whole weekend when we did our event. So yeah, find a bariatrictherapist.com, ASMBS for sure.
for
Awaken.
dietitians, do you have specific recommendations?
Health Profs is
Oh
one that
yeah.
you can put in your zip code too and find
What is
professionals in
it?
your area. Healthprofs.com.
How do you spell it? Like
Health
PROF?
Profs, like professor, PROF.
Okay.
Like
Okay. Health
professionals.
Prof.
Yeah.
Sounds good. ASMBS should also have dietitians.
Yes. Yeah.
Yeah. Maybe Ashlyn would find a bariatric RD as a conjunction to the find a
Subset. Yeah.
bariatric therapist.com. I'll have to talk to her
And then
about that.
also too for patients, it's really just about fit. Somebody can be really, you know, great, whatever, psychologist,
Right.
dietitian, counselor, but not be the right fit for you. And so
Right.
finding someone that you feel comfortable with, that you trust, that you kind of click with, you know, that makes
Critical.
a huge difference in that
Yes.
therapy relationship. Then also too, if the provider is not well versed in bariatrics or is kind of shaming or judgmental of you for having had bariatric surgery,
Get gone.
find someone else.
Yeah. Find someone else. So you guys are licensed in North Carolina only, or how does that work?
Yeah,
Okay, so do you do group therapy also, right?
I do. Yeah, I've had a bariatric group. Gosh, they're probably going on 15, 16, 17 years. Not the same, it's not
Yeah,
all the same people, but it's an open group. But, for post op folks, I've run for a really long
yeah.
time.
It's so amazing. I lived in Augusta for like 20 years, and I did a group there, post-op group there, and now I'm in Atlanta, and I'm doing my group virtually, and I have some of the same people who were in my Augusta group. I
Some of
love
the originals, yeah.
yeah, I love group therapy, and people are afraid of it. But I'm telling you what, if you want to do some incredible work and have incredible support from people who really get what you're doing, get into a group therapy for post-ops or eating disorder or whatever you're struggling with yourself, because it is some powerful, it's a powerful experience and very, very supportive.
Oh, absolutely. I thought it was going to be like a 6 week workshopy kind of thing called bariatric recovery for people who were in recovery from either addiction or eating disorders and had bariatric surgery. It was supposed to be, like I said, 5 or 6 weeks, and it ran for like 5 or 6 years because they were like, no, we want more of this. Let's keep
Yeah,
it going.
yes,
Just that
it
support
is.
from people who really understand and get it.
Yeah, absolutely. So I will for sure send people your way. I have an aftercare online program called Berry Aftercare, and it's a daily support from a number of professionals and seasoned post-ops too. So um,
Awesome.
send people that way, and um, I will I will definitely get you ladies some information about the if so, because I think it would be a great, what you're doing is so important and critical, and I value it so very much. So I will do everything I can to let people know about it. Thank you for what you're doing, for your compassion and your dedication to this amazing group of humans that we are privileged to work with.
Yeah,
Yeah,
absolutely.
thank you.
Same to you. And
Yeah.
thanks for having us on to
Oh
be
my
able to
God.
share some of our knowledge with
I am
patients.
so glad to know that there has been such beautiful support going on in your neck of the woods. And what a beautiful neck of the woods. Oh
Mhm.
my gosh. Oh, beautiful.
Yeah, we can't
Okay.
complain at all.
No, not at all. All right, you guys take care. Thank you so much for meeting with me today and for, educating the listeners of Bari Aftercare. And those of you listening, please encourage others to listen to this. This is a lot of great information. And if you've got relationships with your providers, encourage them to listen to this too and to get the book BariEDucated, because it's much needed out there in the professional world. So thanks, ladies. I really enjoyed it. Take
Thank
care.
you.
Have a great holiday season.
You
You
And
too.
too.
I will be thinking of your dog. I
Thank you.
always got a sick dog, so I'm going to follow up, make sure your dog is doing okay.
Appreciate it.
All right, you guys, take care. Have a good
Thank you,
day.
Bye.
Connie.
All
Bye
righty.
bye.
Bye bye.